good morning all. Welcome to Smart Root Academy. So today we are going to discuss about a very important topic. You can get lots of MCQs as well as image-based questions from this section. So listen carefully and take notes if you need. Okay, so mainly two conditions we will be discussing in this class. Okay, so let's move on to the first condition, that is rheumatic fever. So first let's see what is rheumatic fever. Acute immunologically mediated multi-system inflammatory disease that occurs a few weeks after an episode of group A beta hemolytic streptococcal infection and often involves the heart. So in this you have to note carefully about the bacteria name, that is group A beta hemolytic streptococci. So few weeks after an infection with this bacteria, this rheumatic fever will be developing. So few weeks before, the person may be affected or infected with this bacteria, and if the person is not taking adequate treatment for that, then after some time the patient can get rheumatic fever and it can even involve the heart. Okay, is that clear? Next, acute rheumatic carditis, which often complicates the acute phase of rheumatic fever, may progress to chronic valvular deformities. So this rheumatic fever can cause carditis and it can even progress to chronic valvular deformities. Okay, so this is such a serious condition. So let's see how this beta hemolytic streptococci, group A beta hemolytic streptococci, is causing rheumatic fever. So there is no exact evidence, but according to some researchers and all, some hypothesis is made about this thing. So let's see what's that. Similarity between the group specific carbohydrate of group A streptococci and the glycoprotein of the heart valve. Is that clear? The group A streptococci having a carbohydrate, a group specific carbohydrate of group A streptococci is similar to the glycoprotein of the heart valve. You know the way you note the name mimicry here. No? What is mimicry? It is simply imitation. Okay. So the group A streptococci's carbohydrate is imitating the glycoprotein of the heart valve. So if our body is infected with this bacteria, our immune system will mistakenly attack our heart valve instead of this group A streptococci. Is that clear? So in this way, our immunity itself is attacking our body. So it is a kind of autoimmune disease also. So this is the pathophysiology. Here you can see the rheumatic fever or recurrent infection occurred. Cross immune response between host and streptococcal antigens. I explained how it is occurring. The carbohydrate of the streptococci is similar to the glycoprotein of our heart valve. So our body or immune system will attack our heart valves or the endocardium mistakenly. So that is the cross immune response between the host and streptococcal antigens. Abnormal reaction, autoimmunity disease will occur. So that will lead to rheumatic pancarditis. What do you mean by pancarditis? Pancarditis means all three layers. That is endocardium, myocardium and pericardium. These three will be inflamed. Inflammation of the all three layers will be happening. That is known as pancarditis, and especially and mainly it will be affecting the endocardium. So endocarditis in valves, because the endocardium is the layer covering the valves and the chambers of the heart. So endocarditis will occur. And finally, what will be happening? Erosion of the valve leaflets will be happening. So erosion happening due to that fibrous thickening and valves will be thickened. So that will cause stenosis and regurgitation. So the effects of valve stenosis and regurgitation I explained very clearly in the last class. So you can even refer to that also. So finally, this rheumatic fever can lead to rheumatic heart disease, which involve mainly the valves of the heart, and can lead to stenosis and regurgitation and all the murmurs according to the valve affected, the particular symptoms it will be showing. Next is diagnosis. So for diagnosis of acute rheumatic fever, diagnosis, one specific criteria is there for diagnosis. You know the criteria? It is Jones criteria. So this diagnosis part is very, very important, and you can even confuse it with infective carditis diagnosis criteria also. So you should note Jones criteria is for acute rheumatic fever. Okay. So using some major criteria and minor criteria are there. With the help of that, you will be diagnosing the condition along with some essential criteria. So let's discuss about that. First one is carditis. I already said it is the inflammation of the heart. Mostly pancarditis will be occurring. Pancarditis will be occurring involving all three layers of the heart, but mainly and mostly endocardium will be affected. Next is migratory polyarthritis. What is polyarthritis? Arthritis means inflammation of joints. Inflammation of joints. So polyarthritis means more than one joint will be affected, and even it can be migratory. One part will be affected, after some time one other joint will be affected, and mostly long joints will be affected. Long or big joints like ankles, knees, wrist, elbow, etc. And very rarely small joints will get affected. Okay, so this is the second major criteria, that is migratory polyarthritis. Next one is Sydenham's chorea. So this we will be explaining in the next slides. Then subcutaneous nodules. Okay, so subcutaneous nodules will be appearing. Then erythema marginatum. So this is a rare thing. Less than 3% only it will be appearing. This erythema marginatum, especially it's not visible in people with dark complexion. So this is about erythema marginatum. So these are the major criteria. First one is carditis, then migratory polyarthritis, Sydenham's chorea, subcutaneous nodules, erythema marginatum. Next is minor criteria. In this, first one is clinical. Under clinical, fever. Fever will be there for the patient. Obviously, it's an infection, so that fever will occur. Then arthralgia. Arthralgia means pain in joints. Next is lab test. In lab test, elevated ESR, erythrocyte sedimentation rate will be there, or CRP, C-reactive protein also will be high. So these things will be high whenever our body is affecting from any infection. Okay. So then prolonged PR interval also will be there. Might be there. So this is also a minor criteria. Under minor criteria, clinical, under clinical, fever and arthralgia will come. And under lab test, elevated ESR, CRP, and prolonged PR interval will be there. So next is the essential criteria. Along with this major and minor criteria, supporting evidence of recent group A streptococcal infection. Supporting evidence of recent group A streptococcal infection. We should get an evidence that the person was suffered from this group A streptococcal infection. How we can identify that? Let's see. First one, positive throat culture. Positive throat culture or rapid streptococcal antigen test. Okay, so the throat culture the physician will be taking and it will be positive for the streptococci. Okay, so by that we will get an idea that the person was suffering from group A streptococcal infection. Next is elevated or increasing streptococcal antibody titer. The antibody titer will be checking, that is streptococcal antibody titer will be checking, and that will be elevated. So this also will give an idea that the person was suffered from group A streptococcal infection. So how we can diagnose using this criteria? That is if two major criteria is present along with this essential criteria, that is the recent group A streptococcal infection, then we can diagnose that the patient was suffering from RF, rheumatic fever. And otherwise, one major and two minor criteria in the presence of essential criteria should be there. So in this way, we can diagnose the condition. So the specific characteristics of this rheumatic fever, like even the major criteria is most important. So those symptoms you should be thorough with. So let's discuss those symptoms and signs in detail. So the clinical features, under the clinical features, the things we discussed in the major criteria will be mainly coming, both major and minor criteria. So first one is sore throat. So this is not in the major criteria. So this is the first thing which will be mostly happening. Tonsillopharyngitis will be the main thing before a rheumatic fever. But sore throat is a simple disease. We used to avoid that. So if the person is not taking adequate treatment for a streptococcal sore throat infection, then it can lead to rheumatic fever. Although estimates vary, only 35% to 60% of patients with rheumatic fever recall having any upper respiratory symptoms in the preceding several weeks. Many symptomatic individuals do not seek medical attention, go undiagnosed, or do not take the prescribed antibiotic for acute rheumatic fever prevention. This is what I said. Most of the people will neglect this sore throat, so that we will think that it is self-limiting, so they won't seek any medical attention. So they will go undiagnosed. So that what will be there, they won't take the prescribed antibiotic for preventing acute rheumatic fever. So they will be developing this rheumatic fever. So that is one thing. So sore throat will be occurring before the occurrence of rheumatic fever mostly. Okay. Second thing is polyarthritis. We already discussed. Overall arthritis occurs in approximately 75% of first attacks of ARF. The first attacks of ARF, approximately 75% of people will be suffering from arthritis. The arthritis of ARF is acute rheumatic fever, is usually symmetrical and involves large joints such as knees, ankles, elbows, and wrists. I already explained this. Next is carditis. So first attacks of ARF, carditis occurs in 30% to 60% of cases. Clinicians with carditis may present with shortness of breath, dyspnea upon exertion, cough, paroxysmal nocturnal dyspnea, chest pain, or orthopnea will be there. So this is mainly left heart failure symptoms. This paroxysmal nocturnal dyspnea, dyspnea upon exertion, shortness of breath, cough, orthopnea, these are all left heart failure symptoms. This will be occurring in the patients. Carditis may also be asymptomatic and may be diagnosed solely by auscultation or perhaps echocardiography. By taking echocardiography, sometimes this carditis may be asymptomatic and we will only identify this after taking an echocardiography. Next is Sydenham's chorea. SD is characterized by rapid, irregular, and aimless involuntary movements of arms and legs, trunk, and even facial muscles. Along with this, emotional instability also will be there. Emotional instability also will be there. So that is known as chorea. Okay. So in rheumatic fever, specifically Sydenham's chorea will be there. Rapid, irregular, aimless, and involuntary movements of arms, legs, trunk, and facial muscles. Emotional instability also will be there. This is commonly occurring in girls. Okay. Commonly occurring, mainly it will be occurring in girls. Then next one is subcutaneous nodules. Subcutaneous nodules are rarely noticed by the patient because it is occurring in the above the tendons, in the bony prominence it will be occurring, and it won't be that much painful though. So that's why the patient mostly they won't notice it. Okay, so this is also one clinical feature. Then erythema marginatum, approximately 10% of the people only it will be occurring. Even in Indians, less than 3% only it will be occurring. Like chorea, it is very rare in adults. Patients or parents may report a non-pruritic, painless, serpiginous, erythematous eruption on the trunk that is usually noted only in fair-skinned patients. Okay, so mostly in Western countries, we can notice this. In Indians, especially with dark complexion, it won't be that much visible. Okay, so in Indians, we won't be considering this thing. It is not that much visible in Indians. Okay, so then it is a non-pruritic. The itching won't be there, pain won't be there. Only this color change we can observe. So it is less observed in Indians. Okay. The lesions may persist intermittently for weeks to months. It will be present for weeks to months also. Erythema marginatum means there is a pale center, white part in the middle, and it is in the surrounding there will be redness. So that is erythema marginatum. Other symptoms are like fever, abdominal pain, arthralgia, pain in the joints, malaise, and epistaxis. Epistaxis is bleeding from nose. So these are the other symptoms. Then what will be elevated in rheumatic fever? We will see one titer. So we will see one titer in rheumatic fever, that is anti-streptolysine O. This thing we will be checking for the patient. Okay, so this will be elevated and rheumatic fever. Anti-streptolysine O will be increased in rheumatic fever. Next one is Aschoff body. Okay, so this one you should know. These are nodes or nodules present in the heart in RF patients. Okay, so just remember that Aschoff bodies will be present in the heart in rheumatic fever. So this here you can see a heart image. So this is known as McCallum's patch. You heard about this condition? McCallum's patch. What is McCallum's patch? It is the thickening in the posterior surface of left atria and rheumatic fever or rheumatic heart disease patients. That is known as McCallum's patch. So this McCallum's patch is a diagnosis. If the McCallum's patch is present, then we can diagnose that the patient is having rheumatic fever. Okay, so this is one of the feature in this rheumatic heart disease. McCallum's patch present in rheumatic endocarditis mainly. Rheumatic endocarditis. If the rheumatic fever caused endocarditis, then this McCallum's patch, that is thickening in the posterior surface of the left atria, can be observed. Next is the treatment. Okay, so we have 4 steps in treatment. First one is obviously the primary prevention. Primary prevention means before occurrence of RF. That means if the sore throat, that is group A beta hemolytic streptococcal infection, tonsilopharyngitis occurred at that stage itself, we are preventing the condition. We are giving some antibiotics against this streptococci so that it won't progress to rheumatic fever. That is step 1. Then next one is step 2, that is anti-inflammatory treatment. Because in RF, the patient will be having arthralgia, severe arthritis and all. So the patient will be having so much disturbances or so much symptoms. They will be having so much pain. So for that, for carditis, for arthritis and all, we will be given aspirin and steroids. In step 3 will be supportive management. Supportive management will be mostly rest, then symptomatic treatment, and management of complications. So in this stage, we can do, if the patient is not responding to proper treatment of carditis, the valves will be affected, so that valve replacements or surgeries and all also we can do in this stage. So this is step 3. Then step 4 is secondary prevention. Secondary prevention means prevention of recurrent attacks. So in mostly patient with prosthetic heart valves, that is after valve replacement, there is increased chance for recurrent attacks. Okay, so this also should be prevented. So step 1 is primary prevention, that is even before the occurrence of RF, the sore throat will be adequately treated so that it won't progress to rheumatic fever. Step 2 is anti-inflammatory treatment, mostly with aspirin and steroids. Then step 3 is supportive management, rest, symptomatic treatment, everything we will be given because the disease is already progressed. Then management of complications such as valve replacement surgeries and all we can do. And step 4 is secondary prevention, that is prevention of recurrent attacks after the proper management. Okay, so let's discuss in detail what is step 1. What antibiotics we can use to prevent this RF. So this is very, very important. So in primary prevention of rheumatic fever, the main agent we will be using is penicillin, especially benzathine penicillin G as the agent. It will be given IM, intramuscular will be given only once. 600,000 units for the patient. Up to 27 kg, we will be giving 600 units for the patient. If the patient is more than 27 kg, then 1,20,000 units. No, 12 lakhs will be given for the patient. So this is more than 27 kg. This is next agent is if the patient we can even administer orally, then we will be using penicillin B, that is phenoxymethyl penicillin. Okay, so in children 1250 mg will be given 2 to 3 times daily, and adolescents and adults 500 mg. Double the dose will be given 2 to 3 times daily. For 10 days it should be given. So if we are taking benzathine penicillin G intramuscularly, then only once it is needed. But if we are taking orally penicillin B, then 250 mg for children, 500 mg for adults, 2 to 3 times daily orally for 10 days we have to give. So that is about penicillin. And if the person is allergic to penicillin, then erythromycin is usually administered. Erythromycin 20 to 40 mg per kg per day, 2 to 4 times daily. Orally will be given for 10 days. Same 10 days we will be giving. Only this benzathine penicillin G is administered once. So these are the major antibiotics we will be using in primary prevention. This is according to the recommendation of American Heart Association. Next is acute arthritis. If the patient is having acute arthritis, for the treatment of the tract, we will be giving NSAIDs, aspirin, and all we will be giving for the patient. Okay, then an acute carditis, prednisolone, rest, diuretics, and AC inhibitors we will give. Why diuretics? If the patient is having fluid overload due to heart failure, the carditis is severe, then it can cause heart failure also. So for that, we can even administer diuretics in case of fluid overload, if there is any evidence of fluid overload. Then next one is chorea. For the treatment of chorea, Sydenham's chorea, we will be giving diazepam, haloperidol, carbamazepine. It is a more of a psychiatric type of disorder, so that's why we are giving anti-anxietic medications and all. Okay, so this is about the treatment. First one is for the primary prevention, we will be giving treatment for the sore throat for preventing the RF, and if already RF, rheumatic fever occurred, then for arthritis we will be giving aspirin and NSAIDs, and inflammatory drugs we will be giving carditis, prednisolone, rest, diuretics, AC inhibitors we will be giving. For chorea, diazepam, haloperidol, and carbamazepine we will be giving. Okay, so this is if the disease already occurred. And supportive management, we saw that it should be rest can be given, valve replacement can be done, and monitor ESR CRP for duration of symptomatic treatment. Okay, so if the patient is symptomatic, then in between frequent intervals, ESR and CRP level also should be monitored. Okay, so that's all about the rheumatic fever. Next, we are moving on to a similar condition. I am taking it together, so you should not confuse. You should differentiate the conditions. Okay. Next one is infective endocarditis, which is also a similar condition, but it is not autoimmune. Rheumatic fever is an autoimmune condition. No? So in this, the infection will be occurring in the endocardium only. The endocardium will be affected. Endocarditis means inflammation of the endocardium due to infection will be happening in this one. Here you can see the image also. This is the heart. So this is a normal area. And if these valves are affected with bacterial infection, like this, lesions can occur. Okay, so this is known as infective endocarditis. Let's see in detail. Definition: the proliferation of organisms on the endothelium of the heart, that is known as endocarditis. This may occur in heart valve, the lining of a cardiac chamber or blood vessel, a congenital anomaly. So in infective endocarditis, we usually focus on heart valve because mostly the heart valve will be affected because it is covered with the endocardium, and the lining of the cardiac chamber, even cardiac chamber is also covered with this. Also, this heart valve can be affected, the lining of the cardiac chamber or a blood vessel can be affected, or it can be developed in a congenital anomaly. Okay, or already some disruption or any problem in the heart is already present, Then in that, the bacteria can proliferate and further lead to inflammation of endocardia, and finally it is infective endocarditis. So it can occur in a heart valve, the lining of a cardiac chamber or blood vessel, and even in a congenital anomaly also this problem can arise. So what are the major risk factors? It can be divided into high risk factors, high risk patient, high risk factors, and moderate risk. First one is high risk prosthetic cardiac valves. I already said after this rheumatic fever and all, or due to any issues or congenital issues, the patient will undergone for valve replacement. So that the person will be having prosthetic valves. So if the person is having prosthetic valves, there is high risk for development of this infective endocarditis. Next one is history of bacterial endocarditis even without heart disease. So the bacterial, it doesn't develop up to a heart disease. The patient had previous history of bacterial endocarditis, but it doesn't develop to a heart disease, but it was there for the patient. So if such history is there, the patient is in high risk. Frequent monitoring should be done. Then complex cyanotic congenital malformation. So any malformation is already present, then bacteria can come to that area, or any foreign organism can come to the area and can cause IE, infective endocarditis. Next one is surgically constructed systemic or pulmonary shunts or conduits. So for any repairing of any congenital anomaly, if you are using any systemic or pulmonary shunts, as surgically constructed means in that area also bacterial proliferation can occur and it can lead to infective endocarditis. Next is moderate risk. That first one is mitral valve prolapse with valvular regurgitation or thickened leaflets. This is also an illness, no? If the mitral valve prolapse is there, or regurgitation or thickened leaflets or stenosis is already present, then in that area the bacteria can proliferate and can lead to infective endocarditis. So further problem with the valve can occur. Then hypertrophic cardiomyopathy, if it is there also, the bacteria can proliferate. Then acute valvular dysfunction, then most congenital cardiac malformation. So in this we can see that all, if any issues is already present in the heart, any malformations, any dysfunctions, any stenosis, regurgitation, so already any problem is present means in that area the bacteria can proliferate easily and can cause infective endocarditis. So this is about the risk factors. So there are mainly 3 types of infective endocarditis. Let's see. First one is native valve endocarditis, NVE, acute and subacute. So what is this native valve endocarditis? The patient is, or the person is having his own valve and he doesn't undergo any valve replacement. He is having native valve. So native valve endocarditis is happening. So that is NVE, native valve endocarditis. It can be acute and subacute. Acute means sudden progression of disease. Sudden progression in disease is happening in acute, and in subacute. So if the sudden progression means within weeks. Within weeks, the symptoms, signs and symptoms will progress and it will cause total dysfunction or major problems in the heart can occur within weeks. And even if it is not properly treated, it can lead to death, that too within weeks. Okay, so this is the progression will be sudden. So proper treatment will be given. Otherwise, even death can also happen very fastly. That is within weeks it can occur. Then subacute, there will be slow progression. slow progression will be there in subacute, so that we will get some time for the treatment. Okay, so and then also it should be treated properly. Next one is prosthetic valve endocarditis, PVE. It can be early and late. Okay, so if the patient had undergone valve replacement, so the patient is having a prosthetic valve and the prosthetic valve is infected with the bacteria and caused endocarditis, then that is known as prosthetic valve endocarditis. It can be early. Early means within 2 months or less than 2 months. Within 2 months, if the endocarditis or the valve infection occurred, means that is early. And after 2 months, if it is occurring, that is late. So if within 2 months or less than 2 months, if the infection is occurring, what that means, during the surgery itself, it was not done properly, or any bacterial invasion during the surgery, or it may be iatrogenic, physician induced or healthcare professional induced, it can be. Okay, so if it is after 2 months, it can be community acquired or any other reasons. Okay, so that is prosthetic valve endocarditis. Next one is intravenous drug abuse, IV uses. The infective endocarditis can occur. How? Because they are not following proper sterile methods. Sterile methods they are not following. So due to that, they are even changing the, they are not even changing the needles. So many people are using the same needles. They're not cleaning the area. So they are not properly using the, they are not following the sterile methods. So due to that, in intravenous drug abuse, the endocarditis can occur. Okay. So there are 3 types: native valve endocarditis, prosthetic valve endocarditis, and intravenous drug abuse endocarditis. So these are the main 3 types. Next, we are moving on to the pathophysiology. How this bacteria is entering our body, how it is proliferating, etc. We are going to discuss. Pre-existing cardiac lesion. Okay, so I already said, if there is already a cardiac lesion or any malformation in the area, there will be endothelium damage. So due to that cardiac lesion, endothelium damage will be there, and there will be sterile thrombus. So any damage in the heart, that will cause stasis of blood. Stasis of blood. So that will cause thrombus. So that will be a sterile thrombus. That means there won't be any bacterial invasion to that thrombus. Then if that thrombus is present, then if at any way, if bacteria is entering our body, it will adhere to that thrombus. Transient bacteremia, that will cause adherence of bacteria to that already existing malformed area. If there is a pre-existing cardiac lesion, thrombus will be developing, and at by any route, if bacteria is coming inside, it will adhere to that area. And what will be happening? Microcolony formation by the bacteria. So the proliferation of the bacteria will be occurring in that area. Vegetation. Vegetation means already endocarditis has occurred. So if once this bacterial endocarditis can occur, it can cause local destructive effects. That means the area which it is affected, it will destruct that area. And other symptoms are like embolization. It can cause focal infection, post-response related complication can also occur. So let's see one image so that it will be more clear for you. So here you can see, this is shown like in IV abuse, or if we are also not giving the injections in a proper way, or the needle is not sterile, we are not following sterile methods, then bacteria can enter the bloodstream of the patient. Pathogens gain transient access to the bloodstream. Okay, so it can be through the bloodstream, or through the nose, or through the air. If the bacteria is entering the body also, it will finally it will finally get access to the bloodstream. So at any ways, if the bacteria is entering the bloodstream, finally, if it is going to the heart, you can see in the heart, if the bacteria is entering, this yellow dots here, it is there in yellow dots, you can see it is the bacteria, and this violet color thing, this is the activated platelet. This one is protein, sample fibrin. Then this is the endothelial cells. So we are studying about endocarditis, no? So this is the endothelial cells. So this type of image is the subendothelial matrix. So you can see the stages. First one is pathogens. The first stages. The first stages, the pathogens gain transient access to the bloodstream. So bloodstream, the pathogens gain access to the bloodstream. Then B is blood flow will be happening to the heart. So finally, the bacteria enter the heart also. And adherence to injured or inflamed valve surface. So already some malformation is there. Already some malformation is there. That is, continuity of the endothelial cells is not there. Some injury or some inflammation is present in this area. In that area, the activated platelet cave, the fibrin is there. So they are trying to heal that area. So if the bacteria is also gaining access to that area, it will try to proliferate or adhere to that area. Okay. So that will be, so the bacteria enter the area and try to adhere the area. Then in C, third stage, persistence of bacteria. The bacteria will persist in that area. The cell cannot, the other or body cannot fight, and the bacteria will persist in that area. It will even infect the other cells. It will affect those area, and it will gain access to the normal cells also, and it will infect the other cells. Here you can see. And finally, what will be there? Proliferation. Proliferation of the bacteria. So much bacteria is present, and it will kill the normal cells. Here one cell was there, it was killed, and it is killing or destructing the normal cells. This is known as local destructing effect of the bacteria will be occurring here. It will further damage the area. Then dissemination. Spreading of the total spreading of the infection will be happening. Infective endocarditis will occur. So local destruction will be happening, and that leads to symptoms of infective endocarditis. Okay. Next is the clinical manifestations. So these clinical manifestations are very important. Even you can get image-based questions from this clinical manifestation. So noted. First one, the general manifestations may be mistaken for influenza include vague complaints of malaise, anorexia, weight loss, cough, back and joint pain. So these are the general manifestations. So this manifestation won't be, this manifestation can occur in simple fever, cold and all. So this malaise, weakness, anorexia, decreased appetite, then weight loss, cough, back and joint pain. These are general manifestations. So it can be mistaken for influenza also. So these are general, but there are some classic symptoms or some specific manifestation of this infective endocarditis, which are very important. So let's see that. Classic signs. Fever is always present and it's usually high. This is not a classic symptom. Heart murmurs indicate valvular damage from vegetation. Okay, so this heart murmurs, it can occur in even with any other valve dysfunction, which can be due to any other symptoms also, which can be due to any other diseases also. That heart murmurs will also indicate the valvular damage from vegetation. So in infective endocarditis, due to vegetation, valvular damage is occurring, means the heart murmurs will be there. Next one is petechiae common but non-specific finding. It is due to bleeding into the skin. Splinter hemorrhages. This is one of the classic symptom in an infective endocarditis. This is dark red linear lesions in the nail beds. Okay, in the nail beds, the dark red linear lesions is there. That is known as splinter hemorrhages, which is a vascular phenomena and one of the classic signs in the infective endocarditis. So that is there. Next one is Osler nodes. Okay, Osler nodes. These are tender subcutaneous nodules usually found on the distal parts of the digits. Okay, in the fingers, this Osler nodes will be there. This is also one of the classic signs in infective endocarditis. So it is tender. That means it will be painful. Painful subcutaneous nodules that is present mostly in the fingers of the patient. Okay, I will show you the image so that it will be more clear for you. Next one is Janeway lesions. These are non-tender. Identify the difference between Osler and Janeway. That is Osler, it will be painful and it is present in the fingers of the patient. The digits in the distal parts, it will be present. And in Janeway lesions, it will be non-tender maculae on the palms and soles. On the palms and soles, it will be present. It will be non-tender. It won't be not painful. It won't be painful. So this rough spots will be retinal hemorrhages. So these are the classic signs. So here you can see the image so that it will be more clear for you. Osler node. It is the painful subcutaneous nodules present in the fingers. It will be mostly occurring in fingers. So this is Osler node. In Janeway lesions, it is mainly occurring in palms as well as soles. This Janeway lesions will be occurring in palms and soles. This is not painful, not tender it will be. Okay, so this is Osler node and Janeway lesion. Splinter hemorrhages, you can see. In the nail buds, this is known as splinter hemorrhages. The nail buds, it will be occurring. This is also one of the classic signs of infective endocarditis. So for assessing the patient with infective endocarditis, mainly this classic signs should be assessed. So for diagnosis of this rheumatic fever, we were following Jones criteria. Diagnosis of rheumatic fever, we will be using Jones criteria. So for diagnosis of infective endocarditis, we will be using Duke's criteria. Okay, so should not confuse. For diagnosis of RF, Jones criteria we will be using. So this Jones criteria is given by whom? Jones criteria is given by Dr. T. Duckett Jones. Jones criteria for rheumatic fever is given by Dr. T. Duckett Jones. Okay. And for infective endocarditis, the criteria is Duke's criteria. So this is the modified Duke's criteria. So first let's discuss about the criteria. Major criteria means microbiological evidence of endocarditis in blood culture. In blood culture, we will see the organisms which cause endocarditis is there or not. So it is the microbiological evidence in blood culture of the typical causative organisms. So the typical causative organisms can be HACCP organisms, streptococci, all can cause endocarditis. So we will see the cultures and we will see whether the typical organism is present or not. That is microbiological evidence. Next one is positive echocardiogram showing vegetation and associated valve damage. In second major criteria is the echocardiogram. In echo, if there is vegetation, that is bacteria. Under minor criteria, predisposition to getting endocarditis. That is risk factors if it is present. That is any valve abnormality or any congenital abnormality or any malformation or any anomaly in the heart is already present. Then there is, we discussed that it will cause endocarditis. So predisposition to getting endocarditis. Any such evidence, if it is available or not, we will be seeing. And if it is, whether there is fever more than 38 degrees Celsius, vascular phenomena means that is splinter hemorrhages will come. Any such hemorrhage into the hand or any bleeding manifestation if it is showing, that classic sign is splinter hemorrhages. If it is present, that is also a minor criteria. Then elevated CRP. Elevated CRP means what is the normal level of CRP? Less than 3 is considered as normal. Even it is between 3 to 10 also, it is considered normal, or minor elevation, minor increase, and 10 to 100 if the CRP is, that is moderate elevation, moderate increase, and if more than 100, that is severe or excessive elevation. Okay, so this is about CRP. So if CRP is elevated, that will also comes under minor criteria. Then immunological phenomena. Under immunological phenomena, this Osler's nodes, Rhodes spots will come. Okay, so we will see whether these signs are present. Then it will come under this minor criteria. Then blood culture finding not fitting into the major criteria. So in major criteria, the microbiological evidence, what we will be seeing is typical causative organism, whether it is present in the blood culture or not. That we will be seeing in major criteria. Even if the typical organism is not there, but also the blood culture is positive for some other organisms, then we can say that it will come under minor criteria. Okay, but if the typical causative organism is not present, but the blood culture is positive for some other organisms, then it will come under minor criteria. This is little confusing, it seems. So let's explain once again the modified Duke's criteria. Under major criteria, only 2 are there. That is, first one is microbiological evidence of the typical causative organism infection in the blood cultures, if we can find that. Then in second one is positive echocardiogram showing vegetation and associated valve damage. Okay, the echocardiogram is showing vegetation and associated valve damage. These 2 will come under this major criteria. And under minor criteria, predisposition to getting endocarditis, that is already persisting some anomaly or any valve abnormality. The next one is fever more than 38 degrees Celsius. The third one is vascular phenomena, that is splinter hemorrhages and elevated CRP. Immunological phenomena is the fifth one. Under immunological phenomena, we have to observe presence of Osler node, Rhodes spots in the patient, or Janeway lesions. Then under blood culture, if it is not even positive, if the blood culture is positive for other organisms also, we can say that it will come under minor criteria. So how we will be diagnosing the condition is like, if 2 of the major criteria are present, then we can say that the patient is having infective endocarditis. Otherwise, 1 major is there and 2 minor. 1 major or 2 minor criteria is there, then also we can diagnose the condition as infective endocarditis. Otherwise, if two of the major criteria is not present also, five minor criteria is present, then also we can say that that is infective. So there are three ways for diagnosis. Two major criteria is positive, then we can, no need for any minor criteria, we can say that the person is having infective endocarditis. If only one major criteria is present, two minor criteria is also needed for the diagnosis. And if two of the major criteria are not present, then five minor criteria should be there for establishing the diagnosis of infective endocarditis using Duke's criteria. The name you should remember well. Next is medical management. So I said about typical causative organisms, that is as viridans, as bogus. So these are the main typical organisms which is causing adult native valve endocarditis. So these are penicillin susceptible also. So we will be treating with these. So you should know the medical management. Mostly we will be administering penicillin G. Okay, so that is 12 to 18 million unit per day IV by continuous pump, or in 6 equally divided doses for 4 weeks we will be giving this treatment. Penicillin G, 12 to 18 million units per day IV by continuous pump, or in 6 equally divided doses for 4 weeks. Okay. Then ceftriaxone. Ceftriaxone is the other treatment. Any one of the following regimen will be followed. It is not like I had given 4 regimens here. It is not like 4 of them will be followed. No. Only one among this regimen will be followed. So penicillin G we can use. Otherwise, if the patient is even so if we cannot use penicillin G or it is not available, then ceftriaxone can be used at 2 gram per day IV for 4 weeks. It is also for 4 weeks ceftriaxone can be used. Otherwise, we can use the combination of penicillin G and gentamicin, 1 mg per kg based on the ideal body weight every 8 hours for 2 weeks. So if you are using combination of penicillin G is the same. Penicillin G, the same dose can be used, and in and the gentamicin 1 mg per kg can be used. Okay, so every 8 hours for 2 weeks it can be used. So the benefit is we can complete the regimen within 2 weeks. Okay, so that is the benefit of this combination. Next one is in patients who are allergic to penicillin. If the patient is allergic to penicillin, then we can use vancomycin. Vancomycin at 30 mg per kg per day IV in 2 equally divided doses for 4 weeks. Okay, so if the patient is allergic to penicillin, then vancomycin can be used 30 mg per kg per day IV in 2 equally divided doses for 4 weeks. Okay, so the 4 regimens are there. First one is using penicillin G. Otherwise, ceftriaxone can be used. Otherwise, a combination of penicillin G and gentamicin can be used. And if the patient is allergic to penicillin, vancomycin can be used. So any one of this regimen will be used. So that is medical management. Then surgical management. The indications of the surgical management. When the surgical management is needed, that means congestive cardiac failure refractory to standard medical therapy. So if even if the medical therapy is given, then also the congestive heart failure occurred, then we have to go for surgical management. Or if there is fungal infective endocarditis, then also the surgical management is indicated. What surgery we will be doing? Mostly in infective endocarditis, the valves will be affected. So that valve repair or replacement is the important surgery we will be doing in infective endocarditis. So we discussed about the management. Okay, so if it If the condition worsens, then the medical management is of no use. Then we have to go for surgical management, and the surgical management itself can cause some complications. So better prevention is always better than cure. So how we can prevent this infective endocarditis? Let's see. Pre-procedure antibiotics for mainly for oral procedure like tooth extraction and all, we will be giving antibiotics priorly. So you also may be knowing that before tooth extraction or any other oral procedures, priorly itself, we will be giving antibiotics for prevention of this infective endocarditis, because mostly after this oral procedures, bacterial invasion can happen and that can lead to infective endocarditis. Next one is maintaining good oral hygiene. Gingivitis is the most common source of spontaneous bacteria. So good oral hygiene is one of the main thing in prevention of infective endocarditis. Next one is antibiotic prophylaxis is recommended for invasive respiratory tract procedures that involve incision or biopsy of the respiratory mucosa. Example, tonsillectomy or adenodectomy. So any such respiratory tract procedure or any surgeries we are doing in the respiratory tract or in the throat or in the mouth, then we will be giving antibiotic prophylaxis. Next one is patients with high cardiac risk who undergo a surgical procedure that involves infected skin structure or musculoskeletal tissue. So in normal patient itself, if you are doing any oral procedures or any respiratory tract procedures, then we will be giving antibiotics. And in patients who are with high cardiac risk, even with any skin procedures, any surgical procedures involving skin or musculoskeletal tissue also, we will be giving this antibiotic prophylaxis. So how we will be giving this prophylaxis? Standard general prophylaxis as a single dose 30 to 60 minutes before the procedure. 30 to 60 minutes before the procedure, standard general prophylaxis, a single dose will be given. So that is amoxicillin. Amoxicillin we will be mainly using for prophylaxis. That will be given as standard general prophylaxis 30 to 60 minutes before the procedure, a single dose. The adult dose is 2 gram per oral. 2 gram per oral amoxicillin. Pediatric doses 50 mg per kg per oral, not to exceed 2 gram per dose. It should not exceed 2 gram per dose. So it is 50 mg per kg per oral in pediatric dose, and the adult dose is 2 gram per oral. So amoxicillin will be given as a single dose 30 to 60 minutes before the particular procedure. If the patient is sick and he cannot take oral medication, then we will go for ampicillin. Okay, ampicillin 2 gram IV or IM in adult, or 50 mg per kg IV or IM in pediatrics we will be giving. So these are the prophylaxis, antibiotic prophylaxis we will be giving for before any oral procedures or respiratory tract procedures, mainly we will be giving. And for cardiac risk patients, the patients with high cardiac risk, even before any surgeries involving skin or even musculoskeletal tissue also, we will be given this prophylaxis. Okay. So this is about the disease condition. Today we discussed about two major conditions. First one is rheumatic fever and second one is infective endocarditis. Previous class we discussed about valvular abnormalities or valvular diseases. Okay, so these two are the major reasons causing valvular deformities in a person. Okay, so in rheumatic fever, it is mainly occurring from a sore throat or tonsillopharyngitis, and if it is not treated properly, it will progress to rheumatic fever. And I also explained how it is developing, and the rheumatic fever is an autoimmune disease. Okay, so finally it will be affecting the valves of the heart, and it can cause pancarditis. All three layers can be affected, and it will lead to signs and symptoms. And in rheumatic fever, for diagnosis, Jones criteria we will be using. We also discussed about major and minor criteria in rheumatic fever, and what we discussed about the clinical manifestation, the classic signs in rheumatic fever also we discussed. Then we discussed about the treatment, how the disease condition will be managed, different steps we will be following in the management, that also we discussed. Then the next condition, infective endocarditis, we discussed about the definition, how it will be affecting, who all are in the who what are the high risk and moderate risk factors for development of this infective endocarditis. Then we discussed about the clinical manifestation, both general manifestation and the classic signs which will be present in the infective endocarditis. Then we discussed about the diagnostic criteria. The diagnostic criteria for infective endocarditis is the Duke's criteria. Okay. Then we discussed about the management, how the disease condition can be managed once it occurred, and under prevention mainly we discussed about the antibiotic prophylaxis. So for normal patient, for any oral procedures and for any respiratory tract procedures we will be giving. Persons with high cardiac risk, for any surgical management involving skin or musculoskeletal tissue also, we will be giving this antibiotic prophylaxis. And the maintenance of oral hygiene is very important, because gingivitis is one of the major factor causing infective endocarditis. And the last one is like, what is the antibiotic prophylaxis we will be giving for infective endocarditis patient. So those who are taken per oral, amoxicillin 2 gram per oral will be given for adults, 50 mg per kg per oral will be given for pediatrics. So that is amoxicillin. If the patient is not able to take oral medication, then ampicillin we will be giving. Adult doses 2 gram IV or IM we will be giving. Pediatric doses 50 mg per kg IV or IM we will be giving. Okay. So last NORSET and all, they asked even dose of the medicines also. So do not leave anything, try to study everything. Okay. So this is about our class today. So I will give you some questions so that you will get an idea how questions can be can come from this portion. The first question is, elevated levels of anti-streptolysin O are seen in. Okay. Anti-streptolysin O will be elevated in which disease condition? First one, subcutaneous endocarditis. B, ventricular septal defect. C, rheumatic fever. D, cardiomyopathy. A, subcutaneous endocarditis. B, ventricular septal defect. C, rheumatic fever. D, cardiomyopathy. The answer is rheumatic fever. Okay, in rheumatic fever, this ASO titer will be increased. Okay, so it will be more than 200. It will be more than 200 and rises within 4 to 6 weeks. This ASO titer will be raised within 4 to 6 weeks. ASO titer, it is increased when we will say if it is more than 200. Okay, so anti-streptolysin O, ASO, will be elevated in rheumatic fever. Next one is McCallum's patch. McCallum's patch is diagnostic of A, tetralogy of Fallot, B, infective endocarditis, C, myocardial infarction, D, rheumatic endocarditis. So, what was McCallum's patch and what it indicates? The correct answer is rheumatic endocarditis. Okay, so it's rheumatic means the autoimmune disorder. So due to rheumatic fever, endocarditis, inflammation of the endocardium is happening means that will lead to this McCallum's patch. Okay, so this McCallum's patch, what was that? We already discussed about it. Posterior surface of the left atrium, there will be thickening and vegetation in the posterior surface of the left atrium is known as McCallum's patch, and it is a characteristic feature or a diagnostic of rheumatic endocarditis. So this is the second question. Next one is, see the image, assess it well. So what this picture indicates? A, Osler nodes. B, Janeway lesions. C, subcutaneous nodules. D, road spots. So if any image-based question comes, you should relate it with theory. So what is Osler nodes? What is Janeway lesions? Just recall that and then try to answer. Okay. So the answer is Janeway lesions. How can we say that it's Janeway lesions? Because I already said that in Janeway lesions, palms and soles will be affected. Okay, patches in palms and soles. You can see that so many patches here in the soles. Both legs it is there. But in Osler knots, and it won't be painful. It's not painful. And Osler knots, mostly it is present in the digits or fingers. It will be present and it will be painful. Okay, so this is Janeway lesions. Road spots is present in retina, so it can be avoided. It is not subcutaneous nodules also. So the answer is Janeway lesions. Okay, so in this way, image-based questions and from the theory, the questions can come. I think you guys are clear with it. If you have any doubt, you can even ask in the next class also. So thank you all. Thank you so much.